Hi everyone, welcome to today's episode of Guideline Review of the Week. As promised earlier, as we had discussed sickle cell anemia last time, I promised that we shall be discussing yet another type of anemia in pregnancy, and it is going to be beta thalassemia in pregnancy for this week. Now, we all must have seen a lot of patients with beta thalassemia trait in pregnancy, and when we had seen them for the first time in our OPDs, we must have wondered as to why doesn't their hemoglobin go above 8 or 9, or often even it manifests as 6 to 7 HB के आसपास. And our first thought must have been that we should aggressively correct it. And often, as a first year resident, we think that overloading or just giving them iron supplementation can help, but it doesn't. And that is what we, of course, learned with time. There is a very different way of managing patients who have beta thalassemia major. So, most of the patients that we see are of beta thalassemia trait. The ones with major have a lot of difficulty in conceiving. They often have primary infertility. Why is something that we learn as we proceed in this chapter. So today I'm going to cover everything, but a major focus of my discussion is going to be on beta thalassemia major, the ones who require multiple transfusions. So after having discussed sickle cell anemia, we have yet another hemolytic anemia this week, and it is beta thalassemia. So welcome. And today's guideline is yet again me going to my favorite green top guideline from RCOG. And this guideline was formulated in March 2014, and over the last decade, there have not been any significant changes. So this guideline stays relevant even today. So welcome and let's proceed. So first of all, what is beta thalassemia and how does it manifest? And first of all, of course, what is beta thalassemia minor, major, and intermediate? So beta thalassemia is a type just like we had sickle cell anemia. It's a type of hemoglobinopathy, and it is one of the more commoner inherited disorders. So the mode of inheritance in this is autosomal recessive. So as we had discussed in the lecture last time of sickle cell anemia, how does autosomal recessive inherit? Both the partners, if they are affected, then the chances of the baby or the fetus inheriting this are going to be very high. Whereas if one of the partners is affected, it becomes very essential on how and on us testing for the partner for the mutation of this hemoglobinopathy. So a very important aspect here is that it is autosomally recessive inheritance, and hence testing of the partner becomes very essential if the mother is carrying this disorder. So it is very common, and the pathophysiology behind this is that there is extravascular hemolysis. Now, in the topic of our live discussion that we have done, we had a live discussion on anemia, various types of anemia. There were two major types of hemolytic anemia. It was intravascular or extravascular. So, intravascular is the one in which inside the blood vessels there is breakdown of RBCs, which is very commonly seen in things like disseminated intravascular coagulation, wherein there are thrombin plugs, platelet plugs, and all those thrombi end up catching all those RBCs and destroying them. But extravascular hemolysis is classically when the hemolysis is occurring in the spleen. It is occurring away from the vessels, it is occurring in the spleen. Spleen is the organ which removes all the deformed RBCs, it removes all the RBCs which have any sort of deformities. So it is done so that it does not go into the peripheral circulation, and only the normal RBCs are sent into the peripheral circulation. So the damaged red blood cells and the erythroid precursors are removed. So thalassemia major inherits or results from the inheritance of defective beta globin gene. अब ये beta globin gene क्या होता है? So the normal adult hemoglobin, that is hemoglobin A, is made up of 2 alpha and 2 beta chains. So 4 chains in total. So beta thalassemia results whenever there is any problem which can occur with the production of beta thalassemia, rather of the beta globin chains. So इसमें क्या क्या problem आ सकता है? So the first problem that can come is that the patient can have thalassemia minor. When I talk of thalassemia minor, before I talk of all this, there are going to be a few nomenclatures which I would want you to know. So if I'm writing just beta, then you have to understand that it is the normal beta gene that a patient has. If I'm writing it as beta 0, it means that there is no beta globin production. Whereas if I'm writing beta plus, it means that there is little, thoda sa globin production. So in beta thal minor, there can be two possible genotypes that this female has. So those genotypes are going to be beta plus, along with, obviously we are inheriting one from the mother, one gene is inherited from the mother, one is inherited from the father. So mother se thoda sa slightly defective beta gene is inherited, which is producing a little of beta globin chain, and the father's is normal, or the other way around. और the other possibility is mother से जो inherit किया है वो बिल्कुल भी नहीं प्रोड्यूस कर रहा है, बट द फादर से जो inherit किया है वो अच्छे से प्रोड्यूस कर रहा है. So the theme over here is that in beta thalassemia minor, there is at least one gene that is inherited from one parent. It can be the mother or the father, that is normal, whereas the other one is either not producing at all or it is producing thoda bahut. So beta thalassemia minor mein major presentation is going to be in the form of microcytic anemia. These patients won't have splenomegaly. The microcytic anemia is also going to be exaggerated whenever there are periods of pregnancy or nutritional depletion. But otherwise, these patients can go through their life without even requiring transfusions, and if at all they require transfusions, it will be during periods of pregnancy. The problem starts when the patient starts getting thal intermedia. Intermedia is basically इसके बीच का. So इसमें भी we are going to have two possibilities. So the first possibility over here is going to be when it inherits defective genes from both the mother and the father. But the defect here is that they both are producing थोड़ा बहुत. So the problem is not complete. थोड़ा बहुत तो यहाँ वहां से तो प्रोड्यूस कर ही रहे हैं. The other possibility is that मदर से कुछ भी प्रोड्यूस नहीं कर रहा है, लेकिन फादर से थोड़ा बहुत कर रहा है. So your theme here is that the patient does not have a normal, ये जो normal वाला बीटा जीन था ये बिल्कुल भी नहीं है in intermedia, but जो genes है at least there is one gene that is producing थोड़ा बहुत प्रोड्यूस कर रहा है. The worst case scenario that can occur in thal intermedia is that एक थोड़ा बहुत प्रोड्यूस करने वाला a gene that is producing a bit of globin chain is present, whereas the other one is not producing at all. So that is the worst case scenario. A better scenario in thal intermedia would be both the mother and the father, they both are producing a little bit of globin chain. But the worst possible outcomes are reserved for thal major. Thal major, where do we see them? We see them in the thal major blood transfusion department. All those pediatric patients who require multiple transfusions every month. So these are the patients in which there is just one possibility, in which there is no production from either the mother or the father. So these patients will have only a functional alpha 2 gene. They won't have any beta gene. मतलब beta gene है, but it is completely defective, which is like having a useless gene. So these patients will have proper full-blown microcytic anemia, which will even result in massive splenomegaly. These patients are going to be having severe bone deformities, severe endocrinological problems, severe deposition because of multiple blood transfusions. They will have depositions of iron. Iron overload hoga. That iron is going to be deposited in all the organs, especially the heart and the liver. And these patients have a very bad outcome. In fact, thal major, if it is detected antenatally when the female is pregnant by doing amniocentesis or chorionic pillus sampling, is one of the indications for MTP, medical termination of pregnancy, because it is kind of a disease which is not technically lethal, but will lead to a very poor quality of life for the person when it is born. These people generally live up to the age of 20 to 25 years and they succumb. A lot of them can even succumb inside the mother's uterus by having hydrops fetalis. So thal major, not often do they succumb inside the uterus, kabhi kabar hota hai, but if they are born, they have a very short lifespan because of the iron overload problems that they face throughout their lives. So यहाँ पे उन्होंने वही explain किया हुआ है that in patients who have thal intermedia, it is defined as a group of patients in whom the beta thalassemia severity varies. Why does it vary? Because ये दो उसमें अलग अलग genotypes possible है. At the severe end of thalassemia intermedia are patients who are diagnosed between a young age of 2 to 6 years. This is the one, ये जो यहाँ पे मैंने लिखा हुआ है. सो दिस इज द वन. थैल इंटरमीडिया का जो वर्स प्रोग्नोसिस है वो ये वाले रहेंगे जिनमें एक जीन थोड़ा बहुत प्रोड्यूस करे एंड द अदर जीन इज कंप्लीटली डिफेक्टिव. सो दे विल बी डायग्नोस्ड अराउंड द एज ऑफ 2 to 6 years एंड दे कैन सर्वाइव पॉसिबली विदाउट रेगुलर ट्रांसफ्यूजन्स, but the growth is going to be impaired. The growth and development is going to be impaired. Why is the growth going to be impaired? Because iron जो उनका breakdown से बाहर आने वाला है, all that iron is going to go and deposit in the pituitary gland, which is going to affect the secretion of growth hormone. So that is going to be impaired. At the other end of the spectrum, these patients are the ones जिनमें ये है, जो पहला वाला है. These have a little better prognosis क्योंकि दोनों genes थोड़ा थोड़ा both are producing a bit of beta globin chain, and hence at the other end of spectrum there are patients who are completely asymptomatic until adulthood, and they're present only with mild anemia and splenomegaly occasionally whenever there have been some studies. RBC or CBC has been done from some disorder. Let's say that the patient is having fever due to something like dengue, and for that you have tested the complete blood count, and at that point of time you get to know that, oh, this patient has thal intermedia. So it is more or less an accidental diagnosis. So how do we manage these patients of beta thalassemia, be it major, minor, or intermedia? Mainly the major patients. Of course, the person's own bone marrow is producing defective RBCs. So I need RBCs from outside so that I can have a normal lifestyle. So blood transfusion, and because of multiple blood transfusions along with the hemolysis that is ongoing in my body, because I have beta thalassemia, I will need that excessive iron to be removed from my body. So what we call as iron chelation. What is iron chelation? Chelation matlab I give the patient some drug or a compound which pulls all the iron from the body and excretes it from the body. So iron chelation and blood transfusion are the two ways in which these patients will be carrying on with their lives. The problem though is that ये जो iron overload होता है, if the chelation is not adequate enough, it will lead to deposition of iron in the liver, in the heart, and in the endocrine system. In the endocrine system, more specifically, three places: pituitary gland, thyroid gland, and the pancreas. So again, over here, the anterior pituitary, which is the main pituitary, which anterior pituitary is the one which secretes all the major hormones, be it your thyroid stimulating hormone, be it your FSH and LH, the gonadotropins, or be it your ACTH, that is adrenocorticotropic hormone or growth hormone. All these major hormones are secreted by your anterior pituitary, and your anterior pituitary is very sensitive to even slight increases in your iron body iron load. So iron overload will lead to a dysfunction of them, and because of that, because all your hormones, especially your gonadotropins and growth hormones, and also your ACTH is delayed, or rather is dysfunctional, puberty is going to be delayed and incomplete, resulting in low bone mass. Now you do know that puberty is your major age in which your bone length increases, your bone mass increases. So it's a very crucial period in which if there is any problem in your growth hormone, it will lead to low bone mass. These women are also subfertile. Subfertile, I'm not saying infertile, but they're subfertile. I mean, their fertility is reduced from the usual normal population because of hypogonadotropic hypogonadism. What does this mean? Hypogonadotropic. What is gonadotropin? Basically, FSH and LH. Now, because FSH and LH are not secreted, they are not able to act on the ovary. Ovary is unable to secrete estrogen and progesterone. So there is hypogonadotropic, which relates to the pituitary. Hypogonadism, gonad yani ovary. So because of the low secretion of FSH and LH, your ovary is not secreting enough of the hormones. This will lead to subfertility, and hence they require ovulation induction therapy. We need to give them gonadotropins from outside. We need to give them injections of FSH and LH in the form of HMG or recombinant FSH for them to be able to ovulate and achieve pregnancy. Cardiac failure is the major cause of death because of the deposition of iron in the myocytes. Myocytes are your cardiac heart cells, and hence the problem can be solved by improving your techniques of chelation and transfusion. So you don't overdo the blood transfusion, and also you give adequate amount of iron chelation so that the iron does not find a way to deposit in all these organs. To know on how do I manage or how do I know whether there is iron overload, I have to be doing magnetic resonance imaging. Magnetic resonance imaging में क्या होता है? We check for how the magnetic properties of the muscle or the tissue are with respect to the movement of ions in it. The amount of energy that is let go by the movement of the ions inside the tissue is checked by MRI. That is a very rough way of describing how an MRI works. So if iron is going to deposit in it, this energy loss is going to be very fast because iron in itself is a magnetic ion. It's a magnetic so what I'll say element, and hence it will derange the MRI findings. Since MRI is a very good method for monitoring cardiac, in which we do the T2 imaging of the heart and also hepatic iron overload, T2 imaging of the liver. So this was all about how a patient, how an adult with thalassemia is managed. What is very specific to pregnancy? So first of all, it is associated with an increased risk to both the mother and the baby. So first of all, mother में cardiomyopathy because of the iron overload and the increased risk of fetal growth restriction. Why fetal growth restriction? Because there is hemolysis. If there is hemolysis, not adequate amount of RBCs and oxygen is going to reach to the fetus. So in women who are having beta thalassemia major, these issues can crop up significantly. Also in pregnancy, because there is deposition of iron in all your endocrinological glands. Diabetes mellitus because of poor secretion of insulin from your pancreas. Hypothyroidism because TSH ka secretion is reduced also because iron is going to deposit in your thyroid gland. And hypoparathyroidism again because of the deposition of iron in your parathyroid glands. There is going to be a significant risk that is given to the mother as well during pregnancy. So it is going to be a very high risk pregnancy in women who have thalassemia major. What are the things then I can do to prevent all this? To prevent this, what I can do is aggressive chelation prior to conception, preconceptionally. Q. The drugs that I have, desferoxamine and a few more drugs, these drugs are known to be teratogenic. So these teratogenic drugs cannot technically be given during pregnancy. अगर देना ही है तो the safest drug is desferoxamine, but it also has to be given in the second and third trimester. You cannot give them in the first trimester because they have teratogenicity attached to them. So what is the best thing that I can do? Obviously, first and initial part of second trimester में I'm unable to do chelation, so it is like 4-5 months without chelation. इसमें iron overload बहुत हो सकता है. So I do aggressive chelation prior to the patient conceiving. So desferoxamine is the only chelation agent which has some benefit that has been shown in the second and third trimester. So first trimester में तो कर ही नहीं सकता. So I have to ensure कि prior to conception I am doing an aggressive chelation. कहाँ कहाँ पे ये डिपॉजिट होता है? सबसे इंपॉर्टेंट है पैनक्रियाज. डायबिटीज इज वेरी कॉमन इन विमेन विद थैलेसीमिया बिकॉज पैनक्रियाज में सेटल होता है. What do I have to test? This is a very important question that can be asked in your exams, in your vivas. The test that we do in these women is that we do not check for HbA1c. Q. What is HbA1c? HbA1c is your hemoglobin that is present in RBCs that is bound to glucose. But the problem is that RBCs are being broken down in thalassemia. So the value of HbA1c that you will get would be falsely elevated or falsely below. Hence, HbA1c is not an ideal way of monitoring for sugars in a patient who has thalassemia because इसमें RBCs का breakdown हो रहा है, hemolytic anemia है. So you might falsely get a value that is not actually corresponding to the patient's sugar level. So how do you test them? We use serum fructosamine. Now what is this fructosamine? Fructosamine is similar wherein albumin plus glucose का जो combination है is what we test. Now HbA1c is something that reflects on your previous 2 to 3 months of glucose, whereas fructosamine previous 2 to 3 weeks का तुम्हें control देता है. So it gives you a much more recent control. So it is a much better modality of testing a patient for their sugar control. In fact, not just in thalassemia patients, even in other patients, serious fructosamine gives me a lot more recent values of increasing sugar levels, and hence it is tested. The slight problem though that can arise in serous fructosamine is that albumin reduces during pregnancy. there is hemodilution, and hence there is decreased albumin physiologically in pregnancy. Hence these values can be slightly altered, but the values won't be as altered as in HbA1c, and hence serum fructosamine should be tested in pregnancy. Unfortunately, not a lot of labs do this test, plus it is very expensive. The assay or the test for checking for serum fructosamine is very expensive. Hence we still test for HbA1c, though it is not very good. The HbA1c has to be below 443 millimole, which is equivalent to 6 gram percent or 6%, I would say. So 6% से नीचे होना चाहिए HbA1c prior to conception. Obviously, we have also studied in the chapter of diabetes that the risks of malformations are significantly reduced if the patient has an HbA1c below 6 prior to conception. So diabetes mellitus again is very common in patients with thalassemia. Diabetes is multifactorial. First of all, due to insulin resistance, insulin deficiency, and iron induced islet cell insufficiency. Islet cells are the cells that secrete insulin. So insulin का resistance तो pregnancy की वजह से होता ही है, but also the production of insulin is reduced because of the destruction of islet cells in pregnancy. Apart from that, तो कंट्रोल हैज टू बी आइडियल 4.3 या फिर मैंने बताया 6% के नीचे होना चाहिए. बट अगेन एज आई मेंशनड दैट HbA1c इज नॉट अ रिलायबल मार्कर ऑफ ग्लाइसेमिक कंट्रोल एज इट इज डाइल्यूटेड बाय नॉट जस्ट ऑल्सो जो ब्लड ट्रांसफ्यूजन आते हैं उससे भी डाइल्यूट होता है, प्लस देयर इज डिस्ट्रक्शन hemolysis of the cells, and hence HbA1c is not ideal. The next gland that is affected is thyroid. So thyroid function has to be checked for. TSH levels देखने हैं, free T3, free T3, T4 levels भी pregnancy में check करने हैं. Then comes the most important organ, and that is your heart. Heart में there is going to be deposition. Because of deposition there is going to be cardiac arrhythmias. Because तुम लोग के heart में electrical impulses जो जाते हैं through bundle of His, all the fibers, अगर वहां पे iron deposition होगा तो arrhythmias, because all those ions are going to pull the electrical impulses. Iron is something that has magnetic properties, it will pull all the electricity towards it, so there are going to be cardiac arrhythmias. Also there is going to be iron related cardiomyopathy. So it is a type of hypertrophic cardiomyopathy wherein there is proliferation of the cells of heart. So how do you test for it? So you test for cardiac T2 का time कितना है. So they say that a normal value prior to conception has to be more than 20 milliseconds, whereas a value less than 10 milliseconds is associated with cardiac failure. So severe iron overload is reflected by a T2 value of less than 10 milliseconds. क्या इसका मतलब है? A normal value more than 20 milliseconds, इसका ये मतलब है a T2 milliseconds का meaning ये है that whenever an ion is vibrating in its axis, so when it comes to an equilibrium it lets out an energy. So ये equilibrium पे आने के लिए from an energized state, the amount of time that is required is counted by this T2. MRI का जो T2 का फॉर्म रहता है उसमें. So if there is going to be iron deposition, ये जो energy में आना है वो बहुत जल्दी होगा, hence that time will be reduced, and hence a T2 value of the heart muscle less than 10 milliseconds is associated with severe cardiac iron overload and is associated with cardiac failure. It is also a contraindication to pregnancy along with reduced ejection fraction. Reduced ejection fraction would be because of the iron deposition, and hence the management is by doing aggressive iron chelation and removing the iron from the body. Similarly, iron is deposited in liver. Liver has ferritin in it. It's a major store of iron. Hence liver में it is deposited, and liver का भी T2 scan करना जरूरी है. यहाँ पे भी calculated in the form of 7 milligram of iron per gram of liver का कितना value है. So per gram of liver tissue कितना milligram of iron deposit हो रहा है. So a target has to be reached कि less than 7 milligram is present per gram of liver tissue. If this liver tissue exceeds 15 milligram of iron in 1 gram of liver tissue, the risk of myocardial iron का भी बढ़ने वाला है. And in these patients, desferoxamine in low doses has to be started between 20 to 28 weeks. Ideally, these levels have to be reached prior to conception, but if it is not reached, then between 20 and 28 weeks, we can start this patient on an iron chelating agent, that is desferoxamine. तो यहाँ पे हमने दो चीजें सीखी. एक है लिवर का कैसे कैलकुलेट करना है. So ideal level for liver is less than 7 milligram of iron in 1 gram of liver parenchyma, and for the heart, the T2 values have to be more than 20 milliseconds. Again, cholelithiasis is very common in these women because of the underlying hemolytic anemia. Hemolytic anemia, so there is going to be an excessive bilirubin that is released. ये bilirubin जो है that is going to lead to cholelithiasis, very similar to something that happens in patients who have recurrent bouts of malaria. So they can also develop cholecystitis because of recurrent cholelithiasis. That stone, that gallstone can go and get trapped in your bile tract, and it can lead to cholecystitis, which is basically the inflammation of your gallbladder. Liver cirrhosis and active hepatitis C infection. If these women also have hepatitis C RNA positive, then it can lead to liver cirrhosis at a much younger age. Apart from that, bone density has to be checked. क्यों bone density? क्योंकि इनका puberty के age में because of the lack of growth hormone का secretion, they had very poor bone development. Hence a bone density scan, DEXA scan जिसे हम बोलते हैं dual एब्जॉर्प्शन एक्सरे ड्यूअल एक्सरे एब्जॉर्प्शोमेट्री जो है डेक्सा स्कैन करना बहुत जरूरी है फॉर दीज पेशेंट्स टू नो वेदर दे हैव osteoporosis. It has to be corrected prior to conception. Also, serum vitamin D concentrations have to be optimized so that the bone levels can be optimized. Osteoporosis is again a very major finding. Due to this reason, for women who are having osteoporosis, in these women we give bisphosphonates like zolendronate, alendronate, ये सब जो आते हैं. The problem though is that these drugs are again contraindicated in pregnancy. So bone का भी जो mass है ये preconceptionally हमें ideal करना है. So ये एक और बात हो गई. Apart from that, because these cells are defective, body does some way to destroy them. So alloimmunity, wherein autoimmunity is induced, red cell antibodies can be there, and these red cell antibodies can even go and affect the fetus. So finally, preconceptionally, what all do I have to see if I'm going from top to bottom? सबसे पहले मुझे सब hormones मेरे देखने हैं. Hormones में आता है TSH levels देखना है. TSH levels कैसा है, normal है या नहीं देखना है. I have to check for HbA1c. I have to check for blood sugar levels. I have to do a heart ka scan. Heart ka scan will be done to check for the cardiac iron levels. Then I have to do a liver ka MRI to check for कितना gram of iron is there in कितना milligram of iron is present in कितना gram of liver. After that, I have to come and check the bone का age. Bone का age में check कैसे करूंगा? By doing a DEXA scan. अगर osteoporosis है, it has to be treated prior to conception. These women are often on several drugs. These drugs, सबसे important तो इसमें आता है desferoxamine. It has a very short half-life and it can be used during ovulation induction therapy, but not beyond that. Once she conceives, it has to be stopped. So it has to be avoided in first trimester, whereas it can again be used after 20 weeks of gestation. Bisphosphonates, which are drugs that are used for osteoporosis, are contraindicated in pregnancy and have to be continued at least 3 months prior to conception. In these women, it is very important. Pre-genetic conception counseling is very important. You have to test the partner, the mother, for these genetic things. If the patient has conceived, or if a patient has history of having a kid who has beta thalassemia major, then you can do pre-implantation genetic diagnosis, and then you can do IVF and ICSI. So basically, I just choose the ovum and the sperm that does not contain that gene, and I do IVF and I give that embryo inside. So pre-implantation. So when that embryo is formed, I check that embryo cell whether it has that gene का deformity. Does it have that genetic defect which can lead to beta thalassemia major? So prior to implantation of the embryo, these are the tests that I have to do. What are the other conditions that require such testing? बीटा थैलेसीमिया तो हमने बात कर लिया है. बीटा थैलेसीमिया के बाद सिकल सेल अनीमिया, HbE. अपार्ट फ्रॉम दैट इंपॉर्टेंट में आता है डेल्टा बीटा थैलेसीमिया एंड HbC वेरिएंट. सो यू हैव टू चेक फॉर दीज डिसऑर्डर्स इंपॉर्टेंटली HB इलेक्ट्रोफोरेसिस करके इन द मदर एंड द पार्टनर. इफ द मदर इज हैविंग वन ऑफ दीज डिसऑर्डर्स, द पार्टनर आल्सो हैज टू बी टेस्टेड विद अ हीमोग्लोबिन इलेक्ट्रोफोरेसिस टू चेक if they have any of these conditions. Prior to conception, what all has to be done? Now beta thalassemia ये सब जो है वो liver को affect कर रहा है. So hepatitis B vaccination is recommended if these women are HbSAg negative prior to conception. Hepatitis C has to be checked because cirrhosis will be fastened if these women are also having hepatitis C. The women who have had a splenectomy, अभी splenectomy क्यों करेंगे? Because this liver is the source of destruction of all those RBCs. ये लिवर इतना आरबीसीज डिस्ट्रॉय कर रहा था कि बॉडी में कुछ आरबीसीज ही नहीं बच रहे थे. सो इन ओल्डर टाइम्स व्हेन आयरन चेलेशन ब्लड ट्रांसफ्यूजन weren't being done, at that time they would remove the spleen itself so that the poor RBCs, the bad RBCs only keep on flowing in the body until they died on by themselves. So spleen को निकालेंगे तो ऐसे करते थे, but the problem was removal of the spleen was not correcting the problem. The problem was iron overload and the blood transfusion, and hence splenectomy is not done much now. But for women who have already undergone a splenectomy, you have to understand that penicillin prophylaxis is very important. Why is it important? Because they are at a risk of developing meningitis because of Neisseria, pneumonia, and meningitis again because of Streptococcus pneumoniae, and again influenza because of Haemophilus influenzae type B. So these women also have to be vaccinated for pneumococcus, Haemophilus influenzae, and meningococcus. Pneumococcus is given every 5 yearly, meningococcus is given annually or every 2 yearly, whereas influenza is given every year. So the immunization status of these women who are having or who have had splenectomy has to be ascertained prior to conception. And in all the women who have had splenectomy, you have to start these women on penicillin prophylaxis. How do you give penicillin prophylaxis? You can either give it intramuscularly every 21 days, or you can start the patient on tablet pentid, which is a form of penicillin, 400 mg twice a day. These women, as I mentioned, have to be given these vaccines. Pneumococcal vaccine is to be given every 5 years. You have to check for the immunization status of women who are splenectomized. Once the patient conceives, how should she be managed? Again, the same things. I have to look for the heart's assessment. I can do a 2D echo, I can do an MRI, which is safe. Thyroid function has to be checked because thyroid agar disorder hai, it has a bad effect on the pregnancy for the mother as well as the baby. The baby can have cretinism, neonatal hypothyroidism. The patient herself can have preeclampsia, abruptio placentae, delayed labor because of hypothyroidism. So thyroid function has to be checked for. Also liver का एक बार scan करके देखना है. How often do we do a scan? सबसे पहला एक gestation viability का scan 7 to 9 weeks पे करना है. Routine first trimester scanning at 11 to 14 weeks have to be done. Apart from that, everything has to be done as the way it is done in a normal female. Chronic anemia के वजह से because of hemolysis, placental transfer of nutrients and oxygen is reduced, and hence there is often fetal growth restriction. So if there is worsening maternal anemia or if there is fetal growth restriction, regular transfusions have to be given. You do not stop transfusions for these women. The ideal hemoglobin that has to be maintained for women who are having recurrent transfusions has to be around 10. 10 gram per liter has to be ensured for women who are on regular transfusions, whereas women who are not on regular transfusions, then or these women, the ones who have beta thalassemia trait, for them a hemoglobin of around 8 gram percent is enough until 37 weeks of gestation, when you have to transfuse them around the time of labor. So that is how you maintain their HB. So basically for women who are having bad maternal anemia or there is a evidence of fetal growth restriction, regular transfusions have to be given. The women who are already on regular transfusions, for them the goal is going to be 10 gram percent, whereas for women who are not on regular transfusions, for them the goal is 8 gram percent, and until 37 to 38 weeks when they go in labor, you have to give them 1 to 2 pints of blood. Over here they have mentioned the same thing. In non-transfused patients, HB has to be maintained till 36 weeks at 8 gram percent, and transfusion can be avoided prior to delivery, and it has to be given around the time of delivery. Now these women who have undergone splenectomy, spleen also serves as a center where all the platelets are broken down as well as the RBCs are broken down. So once the spleen is removed, these women will have prolific or proliferation of platelets. Their platelet count is going to be very high. So women who are splenectomized and have a platelet count greater than 6 lakh should be started on aspirin. Why aspirin? Because ये जो platelets है, they can lead to the formation of arterial thrombus. Arterial thrombus को prevent करने के लिए I need an antiplatelet agent, and that antiplatelet agent is going to be low dose aspirin, that is 75 milligram per day. In fact, I believe for all women who have thalassemia, you should start these patients on low dose aspirin. Thalassemia major. Women who have undergone a splenectomy should also be considered for low dose molecular weight heparin, that is LMWH, as well as aspirin. क्यों? क्योंकि these patients, because of the excessive number of platelets, can have DVT, deep vein thrombosis, they can have stroke. Plus, pregnancy already is a state of hypercoagulation, wherein because of the increased estrogen, the liver increases the production of coagulation factors. So, increased coagulation factors and increased platelets can combine to form DVT, and hence you have to start these patients on LMWH. If LMWH should not be, if they are not already started, then at least when they are admitted for any reason, be it for delivery or be it for blood transfusion, at least at that point of time, start them on LMWH. They have a very prothrombotic tendency. These women have a prothrombotic pregnancy, not just because of the broken RBCs, but also because of splenectomy. They have very high platelet count, which leads to venous thromboembolism. Hence, you have to start them on LMWH. How do we manage women who have excessive myocardial iron? We have to start these women on low dose desferoxamine, that is 20 milligram per kg per day for a minimum of 4 to 5 times a week from 20 to 24 weeks of gestation, not given in the first trimester and early second trimester. We have to look for values or a target of T2, as we have already spoken, has to be mentioned. More than 20 has to be achieved, whereas women who have a value below 10 millisecond have to be definitely given iron chelation immediately. If a female is complaining of palpitation, she probably has cardiomyopathy. She might also have decreasing ejection fraction on echocardiography. This will give an increased risk of heart failure. If this is happening in ECG and 2D echo is done, and desferoxamine infusion has to be started. Similarly, for women who have excessive liver iron, for them also we have to be, excessive liver iron is basically 15 milligram of iron in 1 gram of liver parenchyma. These patients also have to be started on iron chelation. Intrapartum, there is nothing different to be done. We have to just ensure that continuous electric fetal monitoring is done. It is not allowed to do intermittent monitoring. जब बीच में डॉपलर लगा के सुनोगे नहीं, you have to put that CTG का machine continuously, because these babies, एक तो they have FGR, fetal growth restriction, plus because of excessive platelet count, increased viscosity because of blood transfusions, there can be impaired placental transfusion of the baby, infusion of the baby. Hence, you have to continuously monitor these babies. In women who have excessive iron overload, we can consider that 2 gram of desferoxamine over 24 hours can be given during labor, but it is not generally done. Thalassemia in itself is definitely not an indication for cesarean section, and in fact, you should avoid a cesarean section until you can, because excessive iron transfer, blood transfusion will be required if there is an excessive blood loss in cesarean section. Apart from that, there is no specific evidence regarding the timing of delivery, timing and mode of delivery. Unfortunately, a lot of these women have fetal growth restriction or diabetes, which otherwise necessitates earlier delivery. So, अगर FGR है, so you have to deliver at 37 weeks. अगर diabetes है, तो 38-39 weeks पर delivery करनी पड़ती है. So, not because of thalassemia, but because of the things that occur along with thalassemia is why you need to do early delivery for these babies. If the patient has cardiomyopathy, pregnancy has to be avoided, especially if the ejection fraction is low. If the peripartum HB is less than 10, then you have to keep 2 cross match, and if the HB is below 8, then you have to give 1 or 2 transfusions around the time of delivery. Postpartum breastfeeding is absolutely safe. Even you can start these women on desferoxamine. Patients, desferoxamine is given as IV. It hence is not secreted. It is secreted in breast milk, but it is not absorbed, and hence it is not harmful to the newborn. So you can give iron chelation in the postpartum period. Breastfeeding can also be continued. These women are at a very high risk of venous thromboembolism, as we have spoken about it. So LMWH has to be given for at least 7 days prior to discharge, and if possible for 6 weeks after a cesarean section. And that is how finally you manage these patients with beta thalassemia in pregnancy. So again, revising it a bit, prior to conception, what do we do? Prior to conception, सबसे पहले अपने को genetic screening करना है, देखना है if the partner is affected. Apart from that, for the female herself, you have to check her thyroid, you have to check her diabetes, you have to check her heart and liver. If the female is having difficulty in conceiving, which is very much possible, you have to give ovulation induction. Ovulation induction works even better if iron chelation has been done and her body iron overload is reduced by aggressive chelation. When she conceives, after conception, you have to do the regular scans. If the female is having iron overload, then you start desferoxamine only after 20 weeks of gestation, even that too in low doses. Apart from that, fetal growth restriction is very common, so Doppler studies have to be done to check whether the growth is being impaired and to how much of an extent. Delivery is preferably by vaginal mode. The timing of delivery is guided whether the patient has other complications like fetal growth restriction and diabetes. Regarding diabetes, we cannot use HbA1c because of the breakdown of RBCs. Hence, you prefer to use serum fructosamine for measurement of diabetes in these patients. And that is it regarding this chapter on management of beta thalassemia in pregnancy. I hope you all have understood this chapter. We shall meet next week and with a much better topic in the next week. I think we'll be discussing about ovarian tumors next week. So until then, goodbye and keep watching Grow.